tonight. Before we begin, I just wanted to acknowledge the Aboriginal people as the traditional custodians of this land. For me, that's the Boonwurrung people, which is the land that I'm on now, and I pay respect to their elders past, present, and emerging. So thank you so much for attending this event tonight. My name's Will, and I'm actually the Education Coursework Officer of GSA, which is the Graduate Student Association. And so for those of you who don't know, GSA is actually a student-run organisation that mainly seeks to improve graduate student life. And we do that actually through multiple aspects. So that includes informational events about education and courses, such as this one tonight. Also things like social events, such as our GSA Ball. And that's for graduate students to be able to acknowledge, be able to meet each other and network and just relax a bit, and also by informing policy and advocacy through the university. Sorry, I'm just going to close my window for a second. I'm not sure if you can hear that, but I'm just hearing some noise off the road.
It's not coming through on our end, Will.
Okay, sorry. Thanks, Adam. Sorry, it was so loud in my ear and I couldn't really even hear what I was saying. Okay, cool. All right, I'll move on then. So just a bit before we actually start, I wanted to talk about the motivation behind this event. So we actually did a focus group last year in 2023, which indicated that previous medical students felt that they could have been a little bit more prepared for their MD2 placement, especially because it's the fact of encountering the hospital environment for the whole year, and it can be a bit daunting in those first few months, not knowing who to speak to or sort of how to make your way around the hospital. So we decided to host this event for you new MD2s to feel a little bit more prepared. Something else that we found in the focus group was actually that students really respond to guidance from older and more experienced students, as they can really put into perspective what it's like to be on placement and be in the hospitals. And so we've decided that this event would be best as a student-led event. And so we've actually found some student panelists that I'll introduce tonight. So we have Gemma, who's MD4, Adam, who's in MD3, Anisha, who's MD3 as well, and then we also have Tani, who's in MD4. And so those are the people that you'd be able to see on your screen now. So in preparation for this event, the speakers and I sat down and we actually had to think about what we personally would do differently if we were able to go back to the start of MD2. And we all remember it being a very daunting first experience in the hospital. As I was saying before, that confusion of having to navigate this new environment, and even just know what classes are compulsory to attend and the tasks that you need to complete throughout the year. So the 4 themes that we've identified and would like to discuss tonight are, firstly, the timetabling of MD2, the beneficial activities that you can find on ward rounds, as they make up a big part of the hospital experience, being able to have confidence in the hospital when you're speaking to staff, but also patients, and also being able to tailor and balance your study to the MD2 experience. After these themes, we also have some dedicated time for all of you to be able to ask your questions. And so throughout the presentation, you can either type any questions that you might have in the Q&A function, or save them for the end, and feel free to write your question in and say that you'd want to unmute yourself if you need to explain your question a little bit better. But so I think that's everything from me. And so without further ado, we'll get into the talk. And I introduce Gemma to start off by talking about the MD2 timetabling.
Thanks so much, Will. So hi everyone, I'm Gemma. I am an MD4 Will said. So I thought that I would start by giving you a brief overview of, I suppose, the structure of the year. You probably have a bit of an idea already how that might look, but just going into that a little bit more, and then all the tips and tricks that we can kind of give you to help make your lives a little bit easier. So I suppose it's a good place to start is by kind of explaining what the year's about, which is really dipping your toes into as many, different fields as possible. And I'd say the focus is really to get a feel for talking to patients and learning skills that you can build on in the following years. And I just want to kind of reiterate that no one expects you to make, that rare cancer diagnosis or expects you to know the answers. They're just kind of wanting you to recognize a patient that's well versus unwell and when to seek help. So I just kind of want to reiterate that it's about having a go, and that's pretty much all it is. So this year you'll get to experience some different rotations, including general medicine, surgery, anesthetics, as well as various medical specialties, and of course, as well, discovery, which you guys are probably all experts in after MD1, but also much more of an expert than I am, that's for sure. You also have lots of different classes and things that might be scheduled throughout the year, and it does depend on your rotation. But you will have PP that's scheduled across the whole year, and your CST, which is your clinical skills tutor, and you'll be linked up with a clinical skills tutor for the whole year. For I suppose other different types of classes you'll get to learn about different procedural skills, usually with CEFs or clinical nurse educators. You'll also get to attend bedside tutorials, which usually might be on your ED or surge rotations, for me anyway. You'll have long case tutorials, which we'll talk a little bit more about later on. And you'll also have things like peer tutoring or near peer tutoring. So whether that's by medical students or by junior doctors who are interested in teaching. So I think it's really important just to kind of say that you might actually have to organize some of these classes yourself. So I know it sounds really daunting to start with, but I think it's just important to kind of maintain really professional relationships with your doctors. A lot of them will give you their mobile number. Just be willing to rearrange times and realize that doctors are obviously teaching around their clinical schedules, and then also have a bit of a plan of what you want to do in the lesson. Sometimes the doctor will say that they want to teach you about a neurological exam, and so they'll ask you to find a neurological patient. And sometimes it might be, what do you guys want to learn? And you might want to learn about endocrinology or something different. So just having a bit of an idea and being proactive about finding patients and finding classes or arranging classes that work with your doctor. It's really, really important. There's lots of great learning opportunities around your scheduled classes and beyond your scheduled classes. So first of all, we have ward rounds. So ward rounds usually start from around 8 o'clock. Sometimes they're a little bit earlier for surge rotations. So unfortunately, that's part of it. But yeah, they might start from like 7 onwards. They're a really good opportunity to kind of start getting some practice on writing or typing notes, depending if you're paper-based or EMR. You also get to observe patient interactions with experienced clinicians, check, the med chart, learn about the different medications and how they interact. It's not something you're expected to know, things like doses, but it's definitely interesting and helpful for your learning. Some clinicians will get you to answer questions as you go, as you go around to different patients. Don't panic. It's kind of mostly just to test whether you're willing to have a go or not, and if you're eager to learn. There are outpatient clinics, so they kind of start from 8:30, 9 o'clock. A lot of the time, they're really great opportunities to take histories, do examinations. You might get to parallel consult. If there's not an opportunity to parallel consult, you can sometimes ask them if you get to start off the history and they can finish it off when you run out of questions or aren't sure where to go next, and you can do the examination, or vice versa. I would say they're really good opportunities to do your mini CEXs, outpatient clinics. And yeah, you kind of get one-on-one feedback, which can be really, really helpful. There's also things like theatres that you get to go to. So you can, often there'll be like a sign-up sheet that you'll be provided with by the uni, or that you make yourself based on the theatres and that are actually happening, if you know what they are, or if they're regular theatre lists. Sometimes you'll often get to go, you'll get to watch. Sometimes, if you're lucky, you might get to scrub. If you do get asked to scrub or get asked to go to theatre by a doctor, I would highly recommend saying yes. Obviously, sometimes people don't really have an interest in surgery and you don't want to go. It's a really great opportunity. I know I personally am not a surge gal, but I would highly recommend it just for the experience, because you'll be expected to do things like scrub for other, I guess, procedures and things that you'll be doing. Even just like practicing sterile glove technique, putting on sterile gloves is like really great practice, so worthwhile. Sometimes you'll even be on ward rounds, and the consultants that are going to a theatre list that afternoon will ask you to come along. So really great opportunities there. And they're really great for technical kind of learning in terms of anatomy, and also just understanding that part of the process. And yeah, really great. The other thing that's really important is clerking patients yourself. And the whole idea of this year, as I said before, is to learn how to speak to patients. And one of the best ways, particularly at the start, is to kind of, just have a chat. You don't need a time limit. You don't need the 10 minutes that you get for a long case, or the hour you get for a long case. Not 10 minutes, gosh, that would be terrifying. But the hour you get for a long case, you can actually just go in there and have a chat, and then take as long as you like, and just practice talking to people, and then practice presenting it back to someone, even if it's just a peer. It's a really good way to kind of get your mind in the right space for things that you'll have to do later, in terms of long cases and other things that we'll chat more about later. A good hint, I know you can definitely do it off ward rounds if you find good patients, but a good way to also clerk patients yourself is going up to nurse unit managers or the nurses on the shift and say, hey, do you have any good patients who might be interesting and who might be a good historian? Good historian is like key here. If they're delirious, it's probably not going to be a great history taking learning, opportunity if it's like your first one or two. But yeah, I'd say like there's heaps of opportunities, and it's really important to learn how to clerk patients for yourself, because it's going to be something that you'll have to do often, and it's going to help improve your skills immensely. And then the other thing I wanted to quickly touch on was just about like compulsory classes. I know it's very different for different year levels. PP and CST are the two classes that are pretty much 100% attendance, other than an approved SLOA. And the other tutes aren't necessarily 100%. I'm not sure on what the quota is, but I would absolutely recommend that the more you go, the more you learn. Even if you're not normally that kind of person, or you find you learn better by reading a book, I promise you clinical experience will help you the most in the long run. And at the end of the day, preparing for an exam is great, but preparing for your lifelong career is honestly the best thing that you can do. This is like an awesome opportunity. And I think something I learned not to do is really important. Don't panic, particularly if doctors are asking you questions and you're like, I can't think with you looking at me like this. Just take a second, remember that they don't care if you know the answer. They just care if you're willing to have a go, and they're going to be more willing to teach if the more you put into it. So I think the other thing to be really careful of is if you don't want to be there and you're not learning, if you're not learning or getting anything out of something, don't be afraid to leave, but just do it in a respectful way, and just say, I have a toot, sorry, I have to go. Don't say, I'm not interested, bye. Know when the right time is to leave for yourself if you're not getting what you need out of that session or out of that, ward round. But just remember to be respectful and professional is probably my biggest tip. I suppose that's kind of my take on timetabling and all the different things that kind of pop up. I'm not sure if anyone else has any different experiences. I'm based rurally, so sometimes it can be a little bit different. So if anyone else has any different things they'd like to add, feel free.
I'd like to just, I guess, echo the sentiment you have there about the more you see, the more you learn. I 100% agree with that. Like, certainly going into MD2, I didn't feel like I was very surgically inclined at all. But I wanted to give it a red hot go, and I really liked the ward rounds. They were really quick, which I loved. But also like getting into theatre and just seeing different things and like talking with the surgeons, and they were really nice, and it really kind of went against my expectations of really like mean old people. Maybe it's still like that in some places, but certainly the surgeons I came a lot across were like super nice and friendly and willing to teach. So yeah, give everything a go at least once or twice. And yeah.
Yeah, I had a really good experience in surge, but I still know it's not for me. So you might get swayed or you might not. But yeah, absolutely. Just have a crack at everything and anything. This is like the one chance that you get to do it. And same with like clinical, like summer electives, and when you get to do your selective eventually, like things like that, you basically have a free pass at any hospital as long as you're nice and professional and organize it. So if there's something you really want to do and you're not getting it, make sure you organize to do an elective in it. But I suppose it's not really so much the timetabling side of things, but just a side note.
Oh yeah, the other thing I'll add as well, sometimes like in certain rotations they might just add in like random tutorials, like bedside tutorials or things like that. I think you touched on that, Gemma, but yeah, be aware that some or like tutorials on like reading ECGs, for example, as part of like emergency things. Just be aware that sometimes tutorials can pop out of nowhere. That's just kind of how things go.
Yeah, you always have to check your timetable, all right?
You will be made aware of it, but it may not be very clear.
Might be short notice.
Yeah, short notice.
Yeah, and unfortunately, that's just a bit of playing the game to a degree. Yeah.
I'll just add as well something about timetabling that I experienced. In our group, we actually allocated someone to take the initiative to do all the timetabling for a little bit. And then we just shared that role around so that everyone sort of had a go. But it was quite easy and streamlined to get all our classes down onto our timetable. And so just with that as well, I think as Gemma said, yeah, speaking to the doctors in a professional way, but also taking the last little bit of your tutes, a few minutes at the end just to organize when you're going to do the next class is a great way to sort of catch the doctor's attention and make sure that it gets put down in the timetable rather than having to follow them up at a later date. It just makes it much easier for you guys, and I think keeps it in the doctor's head as well, so they actually remember to come to the tute, because there's definitely a couple of times that we were left waiting with no doctor. So it's really important to do that as well.
Yeah, I remember an 8 p.m. class that a doctor had scheduled based on his clinical timetable, and then he still didn't rock up. So like, it's just very unpredictable. You never know.
Yes, definitely, definitely. All right, so I think we'll move on now to our next sort of area, which is about ward rounds, and Adam's going to speak to you about his experience with that.
Yep. Is there a prompt that's going to come up? Oh, there we go. Perfect. Yeah, I'll just like briefly overview like what ward rounds are. I believe this is like your guys' first potential week, maybe even second week of being with teams. So you may have already gone on ward rounds and have a bit of experience about what's going on. But as Gemma kind of touched on before, they generally start at 8 a.m., especially if like Gen Med, but like your surgical ones might start earlier at like 7 a.m. And yeah, you're essentially just going through, and they can be as short as like an hour. Sometimes they can go for quite a couple of hours, especially on the Gen Med teams. Which is kind of my first point, which is knowing a bit when to be selfish and leave the ward rounds if you find they aren't benefiting you. And again, Gemma kind of touched on this. Like, if you're not getting anything out of the ward rounds, you've got so much other study to do. You've got lectures, you've got tutorials, and then you've got like private study on top of that, and like textbooks or whatever. you're very time poor as a student, and I think standing around for like 5 hours, especially if you're not getting anything out of it, is just a bit of a waste of time. It can be really hard though to build up that confidence to, speak up and be like, hey, I think I'm gonna peel off now. But what Gemma was saying is like, make sure you're very professional about it and not being rude. The easiest way, my go-to line was always just, oh, I've got a tutorial, sorry, I've got to go. But a lot of doctors are really understanding. They understand that you've got other work on, and they know you don't have to be there as well. And it's you're there for your own learning. So again, that sentiment to be a bit selfish, and if you find that the doctors aren't really engaging with you or you're not learning a lot from it, it might be time to peel off. And that's not to say that the doctors don't care about you. The number one priority is always going to be the patient care. Certainly teaching is a priority, but it might not always be the number one priority. And unfortunately, you just kind of got to recognize that. Yeah. My next point here is like contradictory to the first point. Sticking around to the end of your ward rounds can be beneficial at times. I know it can be a bit of a drag, sitting through like those gen med ward rounds, like on for like 5 hours, like it can be a real gruel. But certainly if you're really interested in the team or the specialty and you're getting on well with the team, I think you can get a lot out of it. Just seeing like all the different conditions that come up, what comes up most commonly can be really beneficial. And especially when you get to the end of ward rounds, you find that the doctors have a lot more free time where you can engage with them a bit more. And that could be your opportunity to ask a bit of a deep dive into asking more questions or querying them on things. And you might also get tidbits on things like doctor conferences or like case meetings that come up. They're always really good to go along to. On surgical rotations, as Gemma was saying before as well, the doctors might invite you later on to come along to the surgeries. So certainly it's a really good idea to stick around to then, because generally what happens in your surgical rotations, you have your ward rounds, which are only like an hour or two, depending on the specialty. And then the doctors will go off to surgery. So that's a really good opportunity if you want to experience that. And I recommend trying it at least once or twice. And also you might score a free coffee at the end if you're lucky. So that's always a plus. Next point I have here is taking the initiative to seek out your own learning. A lot of the times, sometimes the doctors kind of just forget you're there. And again, it's not their fault. Like they've got a lot on their plate. They're looking after the patients and things like that. Which means you kind of got to be, the writer of your own destiny. If you want to be able to do something, you need to kind of seek that out a bit more. I found I think most of my mini CXs I actually did on the wards. Otherwise, I did them with like my CST tutor. If you build enough like rapport with your team, just be like, hey, this next patient, they're in for pneumonia. Could I do a respiratory exam on them or something? And it's a really good chance for you to practice an examination in front of doctors, which can be a bit intimidating at first. But that's when you're going to get the best feedback, and certainly like a diverse amount of feedback from everyone. Yeah, and it's a good way to like help out with the team as well. Other things you might want to do is if things are running a bit slow, you can run ahead of the list, like see the next patient, interview them yourself by yourself. Again, it's really good practice for clerking patients, and then come back to the team and give like a bit of a handover. Helps practice your history taking skills, your examination skills, and your communication skills to be able to hand over to a doctor. I think that was really rewarding. Yeah, so I guess like encapsulating that, something I learned is to be proactive. So try to get involved as much as you can on the ward rounds. Otherwise, you might find they can get a bit boring if, you're there for a few hours and just standing around like a wallflower. And then the flip side of that is if you don't find there's any opportunities, or you don't really think you can engage with it, or, you're just burnt out and just want a bit of a break, just leave. That's totally fine. But again, make sure you're doing it in a way that's professional and respectful. Just say you've got a tutorial on, or there's private study you need to do. The doctors usually are quite understanding of that. And yeah, the biggest one is something I learned not to do is never be afraid to say I don't know to a doctor's question or give it a red hot go. Um, I found like pimming questions from doctors, like I've never found them to be nefarious or like nasty. They're always trying to engage you with learning, and that's just how some doctors teach. If you're ever asked a question and you don't know, just like give it a go, even if you're not confident. It's always going to be a learning opportunity for you anyway. Um, and it's a bit of self-respect as well, I think, to admit that you don't know everything and to have that confidence to admit that as well. And that could do wonders for you because then you're never afraid to ask the stupid questions as well or clarify something. Because a lot of the times the doctors chuck around jargon that just doesn't make sense. And you feel like you're expected to know things, but you've only studied for like 1 year to be a doctor. Like these people have studied for years and years. Like you're not stupid. You're still learning. And it's, I think, really rewarding to acknowledge that. Yeah, that's kind of my spiel on ward rounds. Um,
I'll just add as well, something that I sort of found with the ward rounds was, as you said, Adam, like getting towards the end of them can be sometimes beneficial to actually sort of take the time to ask about like the doctor's um, journey through medicine. Because once they sort of finish the ward rounds, they're having a bit of a break with a coffee. You can actually ask them about sort of their training and how they got into whatever specialty ward round you're on. And so that was something that I found was quite beneficial as well, just beyond learning, but also getting to speak about like networking and how to like continue through the medical career.
yeah, 100%. Like I went in and I was like, what's a registrar? What's a resident? I thought they're the same thing. I don't know. I don't know what all these words mean. And then they say things like BPT. What's a BPT? I don't get it. How do I be a doctor? I don't understand. Like sit down and have a chat with the doctors. Like they'll give you really good insight onto like how the system works, as well as if you're interested in something, the pathways into that. Yeah, as Will said, like if you're interested in something, they might say, oh, I did this, but other people do this, or like you can do dual things, or there's heaps of things. Yeah, doctors are always the best source for that sort of information because they've experienced it firsthand.
I might just also add on the networking if that's okay. There's actually a lot more people than just the doctors on ward rounds as well. I'd like encourage you to look around at who's there. Usually the nurses will also attend ward rounds, and genuinely they can be some of the best sources of information and learning opportunities. I would really encourage you to just chat to them, even if you like get them to talk through the medications on your med chart, like afterwards, or you're like not sure about how the patient has been going, um, or what they're doing to care for them, or whatnot. They also know that patient really well. Remember, they're there with that patient all day, every day, and all night. So they know how things have changed for them. And it's really important to kind of get that information if you don't know the patient. So I would really encourage you to think about who else is there. Sometimes there'll be a pharmacist there. There could be any allied health specialties there. It could be worth having a chat to them as well. And the other thing is there's also usually more than one med student on a team. And so don't be afraid to like look to your MD3s, MD4s, who might also be able to answer questions for you in the meantime. Obviously, I wouldn't be standing at at the bedside when the consultant or any other doctor is sitting there trying to actually, talk to the patient and actually round on this patient, and sitting there in the background having a bit of a chat if you know them or whatever, your like peer, the other medical student. But definitely they're a great person to chat to and ask questions of. And if they don't know the answer, then you can both go and learn something from that doctor as well. So, or from any of the doctors, interns, whoever it may be. So yeah, just think about the other people that are around at that ward round as well.
Yeah, definitely. Like I found like asking the MD4 or the intern a question is definitely a lot less intimidating than going
Yeah.
straight to like the registrar or the consultant.
Yeah.
And they're usually not the ones engaging with the patient. So usually it's okay to ask them questions because they might be typing notes or something like that, so they're
Yeah,
you know, interfering with like the patient dynamic things. And
for sure.
and certainly like talking with nursing staff, like if you want to go clerk a patient, the nurse who's actually looking after that patient is always the best point of contact for that, because they know, you know, if there's any changes, if they're appropriate to talk with and have a conversation with, because they might be asleep or they're off for a scan or something like that, and the nurses on the ward will know that.
Yeah. And even for your ED rotations as well. I know it's not really ward rounds, but like your nurses will be your best friends. If you want to do venipunctures and cannulas and things like that, they will A,
100%.
be able to stand there and supervise you, B, show you all their tips and tricks, which are very handy. And yeah, that they will just become your best friends. So
Yeah.
don't discount the nurses was
If
what I
your
would say.
hospital has a phlebotomist, stay with them for like a couple
Yeah,
of hours. You will do it all, and you will be a lot better off for it, I think.
absolutely.
Just one last point I want to add to the ward rounds as well. When you're with your team seeing patients, it's especially early on, it's one of your best opportunities to try to find good patients for long cases, especially when you're starting off and, you know, you're not trying to perfect your technique. You're just trying to have a sit down and have a lengthy conversation. You'll be able to like vet out who's got multiple conditions and comorbidities and who you could have an extended chat with. Definitely a good place to start.
Awesome. Thank you so much for that, Adam. I think we'll move on now to our theme of confidence, which is going to be spoken about by Anisha.
Thanks, Will. So a lot of what I'm going to talk about has already been touched on by the others. So that's great to know that these are like the really important points to take home. I think with regards to confidence, this is like the main hurdle to get over this year. It's the whole point of introducing clinical experiences early. And I think it's kind of like one of the reasons why you were introduced to the hospital so early in MD1. So even though there was like only 6 visits and you probably felt like nothing was really happening in those visits, it was just to get you used to being in that environment, being in a professional environment, and also trying to go and speak to people, patients that you don't know at all, but just randomly approach them, introduce yourself, and ask if you can have a chat. So just because you all come from different backgrounds, you all know different things, I think that one of the most beneficial things, especially starting out, is to start with this buddy system. So kind of go in pairs or maybe even groups of 3s at the start, just to work on that confidence. You also then feel like it's not all on you to carry a conversation. You have a friend there to help you out. If you're trying to go and just like strike up a long case, or even just like learn the structure of a long case, you have a friend to help you out. You guys can like rely on one another to ask those questions that maybe one of you guys forgot. You also don't necessarily have to have a goal for that conversation, but just get comfortable in speaking to patients about their health issues, which might feel totally alien to you because it's not like you do this with random strangers you meet in your life. This is like a hospital specific setting. So yeah, that was probably my main advice to start, is to go with someone else. In terms of talking to medical staff, so I'd say probably no question is a dumb question. If you feel like you're interrupting, you're bugging someone by asking that question, like maybe just wait for opportune times, but absolutely feel like you can ask those questions. And even if you have to preface it by saying, sorry, I have to ask a dumb question here, more often than not, the doctors are going to tell you, like, no, that's not a dumb question. That's an excellent question. And even if it just provides you with some clarity, that was not a dumb question. It helped you learn. It helped you put things into perspective. The other thing with talking to medical staff is you're going to be talking to a lot of different people. So not just doctors. I guess kind of treat everyone with respect. Introduce yourself, explain that you are the second year medical student on this team, and that, I don't know, you're looking for a patient for a long case, or you have a question, can they help? Basically just be kind and respectful to everyone. And keep in mind that occasionally people may not be as kind and respectful back. They may be a little bit short with you, and that probably has absolutely nothing to do with you. Remember, people have bad days and good days. You could just be trying to ask them maybe a complex question while a lot is going on and they don't have the time in that moment to fully give you their time and attention. Don't take that personally, and definitely don't let it impact how you interact with medical teams in future. So even though it might have happened on one chance, you should definitely still keep putting yourself out there. So in that sense, I think resilience is something really important, and to kind of just like shake that off and not take it personally. I think Adam's got a good story for us later about that one, but
I can quickly share that if you like. I won't take up too much time, but yeah, certainly I'm notorious for asking lots of questions, but obviously at appropriate times. I was in the emergency department once, and I was helping. One of the doctors was really nice. They invited me to help with an ankle fixation of someone who had I want to say they broke it. I'm just gonna say they broke it. Anyway, they were given ketamine to help sedate them and as a painkiller. And as we were readjusting it, they started to desaturate, so their oxygen saturations really dropped really quickly. And they were yelling at me, "Oh, drop the bed quick!" And I was like, I didn't know what to do, so I couldn't find it. One of the other doctors found it, and at that point I realized I can't do anything. I'm useless. So I just sat away in the corner and just watched it all happen. It was terrifying. He like kept desatting, and I had to bag mask him. Met call was called. Everyone came in. It was crazy. Eventually they got him back though. It was all fine in the end. He slowly started to wake up, and we finished the ankle stuff, so it was all good. And the team started to dissipate. He was waking up. We were looking good. So anyway, the dust blows over, and the consultant kind of steps to the side and just watching from afar. And I go up to them and I'm like, "Hey, so like, what just happened?" Because obviously I had no idea why the patient started desaturating. That shouldn't have happened. And they've just blown up at me and said that I shouldn't be talking to them. They're busy right now, and they're paying attention to the patient, which wasn't necessarily true. But anyway, the point is it was in no part my fault. I was very appropriate and polite with the question. And sometimes people just blow up on you. And it's not always a reflection of them as well. Like, that's a really stressful experience to be like the lead doctor in a patient who's just crashed in front of you and all this terrible things have happened. Like, it's not a reflection necessarily of myself or of the doctor. It's just circumstance happened to have that. And, that didn't deter me, which was great. I went away and went to one of the other doctors who was on when they witnessed that, and I had a talk with them and a debrief with them. So like, it's just about, again, as Anisha said, having that resilience to, if something bad happens, you don't let it stop you from being the way you were, and certainly not to stop you from being curious. Yeah, that's my tidbit though.
exactly. Yeah. Great story. Thanks, Adam. Okay, so coming to just talking to patients, as a few of you have already mentioned, asking staff for recommendations on who to talk to. So I think, Jemmy, you mentioned going to the A&M first, seeing who is a good historian, who just likes a chat is a great way to get things started. So at least like, this is a safe patient to talk to. Even if you can't think of like everything to go through in a long case, you can still just have a nice chat and maybe like brighten their day a little bit. The other thing I'd found with that is you don't necessarily have to rely on only the medical team that you are paired with for that rotation. For example, I'd see other medical teams doing their rounds, and I might just stop them and be like, hey, do you guys have any patients that you'd recommend would be good for a long case? Chances are they've got at least one. So that's another really good source of finding patients to talk to. The other thing I'd want to mention is try not to set unrealistic goals for yourself, especially like at the start when you're just kind of learning the structure of like how to go through everything you want to talk about. And if you have long case in mind, there's a lot of things to go through. And it takes a while to get proficient and know that structure. So if a long case gets derailed, that's fine. Like it's going to happen. Patients are going to go off to scans or tests, or maybe their family shows up and, you know, they have limited time to hang out with them and visit with them. So kind of just excuse yourself, come back later, maybe if that works for you. Otherwise, if you get half of a long case done, that's fine. Don't beat yourself up about it. It happens all the time. So just know that in talking to those patients, that might have been a nice little break for them. They'd get to have a chat with someone, and you're part of their like care team. So it is a nice thing to do as well. All right. Did anyone else have anything more to say with talking to patients?
I just had a quick story about like my first literally week in the hospital. I like asked an ANUM for if she had like any suitable long case patients, and she was actually on the phone. So I was like waiting at the desk, like really politely, like just for her to get off the phone. And she like turned around to me and she's like, "What?" and like full yelled. And I was like, "Oh my God." So I really felt defeated after that because I was like, "Oh, I haven't done like, have I done something wrong? How am I going to be able to do this?" Like, because it was the first week, I was like, I can't keep asking the ANUM for long case patients. But then I sort of like thought about it retrospectively, actually through a PP assignment. And then I took on like what Anisha said here, like don't take it personally at all, because I was thinking if she's yelled at me within like 5 seconds of knowing me, there's no way that I can take that personally. And then that's sort of a sentiment that I carried throughout the rest of the year, because there was other times where people were short or a bit rude. And so it is definitely something that you will have to remind yourself. But all medical students and all students, like nursing students, physio students, are all in the same boat in the hospital. And it's just that natural hierarchy. And so it's definitely not something that you should take personal at all, or it shouldn't motivate you to continue speaking. It shouldn't stop you from being able to speak to patients and things like that. So I think that was a really good point, Anisha. Really important to remember that.
I think as well with the sorry, Tani.
Sorry, Jenna, go for it.
I'll be super quick. I just wanted to say, like, the other thing with like if someone's being short with you, it also depends on like and I think it's kind of been touched on like what's happening around you and what that person's going through, and not taking it personally, but also like particularly at the start of the year, like around now, for example, all of the regs and HMOs at at my hospital anyway, and probably at all of the other hospitals, have just switched over. And so everyone's new, everyone's just trying to work out where they've got to go, who they got to talk to, how everything works. And that in itself can be really stressful, not just for the new people who have no idea what's going on, but who are, still very clever and competent. They just are in a new environment, and that can sometimes be very unsettling, and similar to how you guys will probably all feel as well. So just remember that everyone else is kind of, to a degree, particularly at the start of the year, in a similar situation. But it's also stressful for the people who are based in that hospital normally, and who are dealing with all these new systems, or the same system that has new people in it who are trying to navigate it. And so things aren't running as smoothly as they might normally, or have to now talk to a different person and they don't have that relationship, or, you know, things can sometimes be a little bit more tricky, just in that, I guess, honeymoon period, let's call it. So yeah, just like going easy on yourself and going easy on everyone else as well, I think is really important in this kind of period, particularly when you're just starting in the first few, like the first month or so. But yeah, just a good thing to remember as, you know, people change over and you switch teams. Sometimes it lines up very well with when you're switching teams, when all the Regs and HMOs switch teams too. So sorry, Tani, I cut you off earlier.
Not at all. All I was going to add to all the sentiments that have been echoed tonight. So I think MD2 for me was a big year of getting used to the fact that I'm going to mess up. It's okay. It's a year of mistakes. You're not going to always say the right thing. You're not always going to get your cannula in. You're not always going to get that blood. And I think it's the first time you've been you've experienced that much volume of here's new stuff for you to do. You're not going to know where things are. People are going to ask things of you where you're like, I don't know where that is on Cerner. And rather than over apologizing, whereas I am very, very guilty of this, just saying sorry for everything, you're not meant to know it. Like, you don't know it. No one has walked you through it. It's okay. And I think just at the baseline, it's all right to not know. If you show me once, I'm happy to do it next time. I think that's all you need to, you know, preface, and it's okay to not know things. I think I took that really personally at the very beginning, like feeling very dumb and silly because I'm like, oh, I don't know where this is, where that is. Follow the nurse to the storeroom and see how they set up their next cannula. You know, follow one of the pharmacists and see where the meds are kept. So just so you have an idea of, like, get your bounds. It's okay to not be perfect to start off with. That's all I wanted to add to that.
Awesome. I think we'll move on to the last theme now, which is Tani. So you can continue speaking, Tani.
Beaut. I'll just keep going then. All right. Study with MD2. Well, if I could go back to MD2, oh my God, there's so many things I would give myself a pep talk about. But I think there's three main points that I would be like, take these and run. Number one, as everyone has talked about tonight, prioritize active hours over showing your face for the whole day. I learned very, very quickly, you need to ask for what you want. You need to walk into a ward round or a clinic and have like an actionable agenda or an item that you want to get done, and flag it with your team when you introduce yourself, like, hey, I'm a med student on today. I would love to practice taking a history. If there's a patient that you think, you know, would suit this, I'd be happy to see them 4 rounds. Exactly. I think Adam talked about it before. Do that. And it doesn't have to be every day, but you'll feel really accomplished if you walk in with like one little thing you want to get done. I think it's a really great way to also build that confidence because you're setting up what you're there for. And often there is a bit of disparity between what the team knows you can do and what you know you can do. So if you bridge that communication gap from the get-go, I think it just helps you get some level of experience a lot easier. And yeah, I think it's just like kindly asking for things when you can, because expecting to be passively taught is a very hit-miss approach, in my humble opinion, especially in MD2. And it takes a while to get there. It takes a while to be comfortable with asking. I'm someone who tries to get out of the way before asking for what I need, but I realized I really needed to advocate for myself, and it was a big learning curve in that respect. The next thing is, if you have clinic, utilize the downtime. And this is one of my hottest tips, I think, if I could go back and change something I approached MD2 with. Like when you go to a clinic, there's going to be moments where it's changing patients, you're waiting for someone to arrive. There's just like a lot of random downtime. So my tip is take an iPad, a tablet, or like a small textbook to clinic. And then between your patients while you're waiting, you can do Anki, you can look up your new presentations, you can go on UpToDate, you can make a quick summary note. Or what I used to also do is practice how to summarize a patient in a few sentences, which is especially useful for long cases. Like, you know, XYZ has come in with this, presented with that on the background of this. So those little summaries are something that, you know, carry over even in future years when you're doing handovers. They become a very, very important skill to practice. And clinic is a great way to do it because you're meeting a patient for the first time and trying to get a, you know, idea of who they are and what the essence of their conditions are. So that might be one way to do it. And all I say with clinic is, I think an iPad or a textbook looks a lot more professional than your phone. So it's a way to have something in front of you, but it not be your phone, but you can still be on UpToDate. You can be looking things up as they're coming through the door. And I think it's what I would do. So if you're looking for an excuse to use your iPad, I think clinic is the right way to do it. And it just looks a lot more professional and put together. Next, surge rotations. I think again, I'm not someone who's particularly surgeon inclined either. So my takeaways, if you don't know what to do, whatever unit you're on, maybe try to figure out what the bread and butter presentations are. Check the surge list and try to see maybe one of them. This might be the classic appendectomy or cholecystectomy or like a joint replacement, you know, just like the basics of what you think you'll see a lot of as a junior doctor down the line, and it'd be nice to see what this looks like from the front to the back. But also to play devil's advocate as well, med school is one of like the only times you will likely have the luxury to stand in a 10-hour liver transplant. So don't hesitate to tick off those bucket list surgeries if you really want to. But yeah, if you're not too sure where to go, I think try look up the bread and butter and maybe make a little list of what you want to see. Most of all with MD2, we've talked about it a lot tonight. I think take the opportunity to practice your exams. If you can walk away from MD2 just comfortable with the motions of doing all the basic exams, I think that's a huge win. And just being able to walk into a patient bedside and confidently be able to, you know, not awkwardly maneuver around them and just look smooth with how you're doing it. I think that would be the biggest win. So in MD2, exams and histories, exams especially, would be a really, really great thing to practice. And more often than not, patients are so happy to talk to you. Like I always was like, oh my God, I don't want to be burdened, especially with long cases when you're sitting there for an hour. But trust me, the oldies will sit there for an hour and more if you let them. So they are so sweet and so kind. And yeah, it I think really helps build your confidence as well, because you're like, oh, I'm actually not just taking up their time. They kind of want to talk to me. But yeah, my second major tip would be re-engineering the way you study to be presentation based. Now, I think this is something you'll hear echoed a lot, but MD2 onwards, it's very helpful to think of study in terms of like, how do I approach this patient with chest pain rather than what can I tell you about nephrotic syndromes? You know, what is going to walk through the door and how do you work them up? And I think the best way to do this is using case books. So these are essentially structured the way short answer questions are. And if you haven't come across many, I've just put a few up there for you. There's the Oxford cases in medicine and surgery. There's Davidson's. And I actually discovered this in MD3, but the 100 cases books are really good as well. They have 100 cases for like everything from peds to women's to GP to anything you possibly want. So they're a really great resource for MD2 and MD3 continuing on. And all of those basically give you patient examples, like hypothetical, and work it up from history, exam, investigations, management. And it's exactly how your short answer will basically be premised. If you're not an Anki person, bar this, but I used to also put those structures straight into Anki and learn presentations that way, because I think it's a really good flow on rather than learning disjointed facts. So I think that's also one way you could re-engineer what you already do. And if you're a note kind of person, I think really starting to restructure the way you naturally note down things into those tables and columns of history, investigations, etc., is helpful. And lastly, of course, practice MCQs. Some popular resources. This is still in the presentation stuff, but some popular resources, I think, are PassMed, eMedici, and AMBOSS. There are plenty out there. I think those are the ones you'll come across most often. PassMed's quite cheap and consistent, very effective. eMedici, I'm pretty sure, is based on the Australian guidelines, and AMBOSS is fab. So all of those are great for MCQ if you need resources as well. Last but very not least, consistent early long case practice. Long case is such a hackable assessment with practice, and I think that you can do very well, if not full market. So let it be reassuring that it is very doable. It's not something that's this scary thing that everyone looms in front of you. It is very doable. You just need a solid approach and a lot of practice. And I think if you ever have a chance to watch the BPTs doing theirs, oh my God, take it and run. Like, it's really nice to get familiar with their structures and figure out also some, helpful, succinct phrasing that they use, because they sound so cute and smart. Like diet-controlled hypercholesterolemia, or like, say, like Mr. Smith is like a long-standing complicated Crohn's patient who's well acquainted with gastro and HPV. Rather than just telling you they're a Crohn's patient, I've given you a bit more context as to the fact that they're quite complicated, and they've already like liaised with a lot of departments. So just like the phrasing that you already use, add evaluative descriptions to level up the way that you're analyzing the patients. Get into the habit of doing, I think, 1 case per week, regardless of your tutorial schedule. Like, if you buddy up with a friend and give each other honest, loving, bullying feedback, and stay consistent with it, it can really be a great way to get into the habit of it early. And if you don't already have a structure or haven't heard of Dr. Pimco, it's a great one to just consider. It's a really good structural tool to help you not miss the details. And I think the benefits of a sound structure is that it makes you so much more comfortable and less susceptible to being thrown when you see a more unfamiliar condition. I say that because my partner had like a polymyalgia rheumatica case for their end of year, and I remember I was like, yeah, if you haven't done rheum or heme, you just walk into that being like, oh my god, this is fun, and not in a good way. Last of all, I would learn to tailor whatever structure you have to a few common conditions. And so on the next slide, I just popped up a little example. This, just for example, diabetes comes up so often. So whenever you use Dr. Pimco, even when you go to interview your patient, this makes you sure you won't miss any little details. And if you go through all of them, so the DRPIMCO stands for diagnosis, risk factors, etc., if you haven't already seen it. But like for type 2 diabetes, in like investigation sections, like make sure you ask them about their daily blood sugar levels, their pre and postprandial levels, their HbA1c readings, their kidney functions if they know them. So you'll come up with a little rolling list for all the common conditions of little questions to ask. And I think if you start doing that, so when you've seen a patient, rather than just having that long case disappear into the ether in your brain, be like, okay, that was a common condition. Can I create a structure that I can use if I see that again? Fabulous, then I'll know these questions to tick off. Anyway, I won't go into it too much. I'm sure you'll have plenty of long case tutorials, but if you haven't heard of it, here you are. And the only other two things I want to say is, I think with long case, learn how to prioritize a patient's issues. Like my end of year assessment for long case back in MD2, the person had 10 plus active medical conditions, and they were all hefty. And many people failed simply due to poor time management. So the trick is always to prioritize the most important issues and acknowledge that, like, the patient might have other inactive medical problems I'd love to elaborate on if proffered the time, etc. But show that you know how to prioritize and know that you can never know everything. You're trying to capture the essence. And last but very not least, I think don't forget patient concerns. If you're ever struggling to prioritize someone's issues because they have an numerous list, it can really be helpful to just consider what bothers the patient the most. Like a patient might have many comorbidities, but if what is compromising them the most is, say, a medication side effect or urinary incontinence, then that should be given prominence because it's of concern to them. So I think those are my hot tips with long case. And general study throughout the year, unless anyone else has something to add.
Just on the long cases, sorry, Adam, do you mind if I go
No,
first?
you go.
I was just going to say, just on the long cases, I think you like sort of touched on a really good idea is to like watch others. And I remember like my like classmates and stuff, we'd maybe get into pairs and then in the morning say, okay, so we'll each go and do a long case today, and then we'll come back to the library in the afternoon and we'll present it to each other. And so I think that's a really good way to sort of like get into it, get into the presentation side of a long case prior to having to do it to like a doctor or like staff, because I think that's like, it's a one big jump to like learn how to do the long case, and then it's a second big jump to actually be able to present one. And so using that time with a partner to be able to practice that is really important. And then just similarly about like presenting a long case, I remember I used to think like before I had done one, oh, I'm just writing down like the notes like as I do the long case and I'll just read them at the end. And then I tried to present my first long case and it was like so different than just like reading the notes off my piece of paper. And so just again, I think, yeah, practicing that presentation part of it. And then, as Tani said, like having that framework to know the questions to ask, but then the way to set out those answers in the long case is really important too.
Yeah, it's also really helpful to see what a good long case looks like. We were presented with opportunities to do bulldogging partway through the year, which is like being a helper for the BPT long case exams. And this was a really good opportunity to see how this is done, and also like at a BPT level, what that long case looks like. So if you have an idea of what a really good one looks like, you can kind of start to learn how to structure yours. And it wasn't even until that opportunity to Bulldog did I really even figure out how I wanted to start structuring and organizing the way that I wrote down information. Because, yeah, like Will said at the start, I brought a manila folder. It was covered in notes. I didn't know what I was doing. I didn't know what was important. Just wrote everything down. But then once I'd seen how others structured it and how to make the important bits of information stand out, that's what you're going to write down. Then I had like a really good way and a good example of how I wanted to do this. And that's what I stuck with for my long case at the end of the year.
Were you going to say something, Adam, before I interrupted you?
Oh no, you said exactly what I was going to say. Like,
Oh,
you're
okay.
assessed on how you present your long case. You're not assessed on how you write the long case. You could be the best history taker in the world, but if you can't present it, yeah. So never do a long case and don't present it. Always present them, even if it's just to another MD2. But preferably, try to get like an MD4 or like an intern or like a higher up doctor, because they're gonna like they've had years of experience of like doing these communication type skills. So like, yeah. But again, an MD2 is fine sometimes, but yeah.
I'm just reminded of another thing, just reading the slide now, just about taking an iPad to clinic. I think that's like also a great way to actually like take your notes and stuff while seeing the patients in the clinic. And if you do have an iPad and you can like sort of look up stuff like while the patient's talking, I think that just helps you feel a bit more prepared to then answer doctors' questions about it. I remember like once I was in an ophthalmology clinic and the doctor asked me like what giant cell arteritis was, and I was like, I don't know, but then I like quickly looked it up like as she was like typing notes, and then sort of explained like what it was, like sort of cheating, but it's like a good way to just feel a bit more comfortable like in that environment, knowing that you have somewhere where you can sort of look to see like what a condition is, so you're not just sitting there wasting time by not knowing what they're actually talking about. So I think that was a really good point too.
The only caveat to that I would probably add is we so like I know quite a few people have taken the iPad to, class or not class, sorry, to like clinics and had them in between. It's just like really important to make sure that you're not necessarily paying more attention to your iPad than you are to your patient. So particularly if there's a patient in the room, I would strongly suggest not being on your iPad when the patient's in front of you. I know it's kind of a little bit contradictory, and your iPad can be a great tool, but I think it's really important to make sure that the patient is comfortable and they know you're actually listening to them and not just sitting in the corner being like, oh yeah, like on their iPad. Because I have heard about people being asked to leave patient interactions and asked to leave the room for similar, like for that kind of thing. And that, those students weren't doing anything wrong. It's just been interpreted that way. So just a reminder that sometimes it's really important to make sure that you're in the right environment to be doing that, is probably what I would say. And like obviously if it's just you and the clinician and they're typing away and you're on your iPad looking things up and learning, that's so fine. And taking notes about like the previous patient that you might have learned about, that's a-okay. But just like when the patient walks in the room, I'd probably suggest maybe not doing that so much, and maybe just like paying attention, because the more you listen, the more you'll take in, and the more you're sitting there trying to write everything down, the less you're listening to what's actually being said in front of you. You're just still trying to write down the last thing they said. Yeah, well, that's how my brain works anyway. So that might be a me issue, but I'll take it. But yeah, sorry to play devil's advocate a bit.
No, that's okay. That's definitely a good point. Patient is always the priority. All right, so I think that sort of wraps up our main themes. So we've learned a lot of different stuff about these things today. So utilizing different activities in the hospital, using a buddy system was really great as well. And just being able to practice your skills consistently is definitely beneficial for this MD2 year. So I think we'll move on to some time for your questions. So just a reminder, you can write your questions in the Q&A function, or if you want to as well, you can write in there if you want to ask a question verbally, and then we're able to unmute you so you can explain your question. But I see we've already got a few questions as well. So the first one was, have you had any difficulties with patients, and how did you deal with that? And I know that I've definitely had poor experience with patients. So just a quick story, and then the other panelists can maybe add on their stories as well. Once I had a patient that was very reluctant to do a long case with me, but the consultant had come around on the ward round and asked her if she would let me do a long case. And so I think she sort of felt pressured into letting me do the long case with her, even though she didn't want to. And so I went into it trying to be very respectful and mindful of that, and said to her at the start, if you don't want to do this, it's okay. And she actually said to me, well, I feel like I have to, because if the consultant's not happy, I won't get the best treatment. And so first of all, that was like ethically, I didn't want her to feel like pressured, or that she had to sort of live up to having like the best treatment, as we should always be treating the patients equally. But she was also sort of reluctant to answer my questions and things. And so, I just reminded her that like she didn't have to do it, and sort of took a bit of a step back. And like Anisha was saying before, not taking that personally, I think is a good way to sort of deal with it. But I think that's probably one of my worst patient experiences. Most of the time they're actually really nice, and especially in the teaching hospitals, they sort of expect that like medical students will be partially involved in their care, and so a lot of the time they are very willing to sort of help you out with those assessments, and provide their stories for your learning. Does anyone else have poor patient experiences?
I might add a little bit in. I would agree to that sentiment though. Like 99% of the time, like they're lovely. Sometimes though you'll notice like they're not really engaging, that, and you kind of just have to give it a feel, and it does take, it's a bit of a skill to kind of get the impression that the patient kind of doesn't really want to talk to you right now. And you just gotta be like, you just got to address that and be like, oh, look, it's okay if you don't want to do this, and be upfront. Like if you're going to do a long case, you need to tell them like this conversation could be up to an hour. Like, are you okay with that? And if you can see a bit of hesitancy, it might be best not to, because you want to be able to engage them for the full hour. You don't want to have to like cut off halfway and then you're left with half a long case. That's not very useful. And then again, not very comfortable for the patient as well. So, yeah, I had a patient though for my professional practice. No, it wasn't professional practice. What was it called when you longitudinally follow the patient for a year?
Patient partner.
Patient partner program, yeah. This is a good story. But essentially, you have to give these patient partners your mobile number. And when she was discharged, she was messaging me with like symptoms she was suffering from. And obviously I'm not trained to be able to do that as an MD2. So there was lengthy conversations with like professional practice tutors and other peers. And I was just like, look, you need to go to your GP or go to emergency if it's an emergency. I am not allowed to like give you any advice. But the takeaway from that is always like, if you run into these problems, like this is what your professional practice classes are for. Like you're going to run into problems on the ward, and that is okay. But like it is very relieving to debrief about it and like get advice and like a bit of validation from your professional practice classes, because it's going to be inevitable that you're going to run into something that kind of, is a bit uncomfortable, or like something outside of your comfort zone. Yeah, I would highly suggest sharing that and being open about those experiences.
Gemma, I see you wanted to answer that question about ward rounds. or on the wards?
Yeah, and I think there's a question that was also sent through in the chat for us that was, what does time on the wards look like outside of ward rounds, and what do you do?
Yeah.
So I'll just
Yep.
answer them both together if that's okay. I think it's kind of interesting because ward rounds you're not really going to get the opportunity to do things like your mini CEXs or any assessments and things like that on the ward rounds. So I would say that time on the wards is probably more so going and seeing some interesting patients that might be with your team that you're working with that day. So going in, having a chat and sitting down and you know, taking a history, doing an examination, and then presenting it back to your consultants or regs or even the interns, whoever's willing to kind of give you some feedback. So that's definitely one thing that kind of is I suppose, time on the wards, like things that would be happening outside of ward rounds. And I would really be prioritizing that, just for the feedback, even if it's not necessarily for an assessment per se, but definitely if they give you decent feedback, or even if they don't, most of the time, if they're willing to sit down and give you feedback, they're willing to probably sign your Kaizen forms or riser or whatever we're calling it these days. But I think as well, like there's definitely opportunities. So doctors usually need to do cannulas if the nurses can't get them in within 2 tries. So the doctor will get called. Usually they're the tricky ones, but sometimes you'll get to have a crack, which is always fun, depending on the patient if they consent. But so potentially like doing cannulas. There's usually quite a lot of ward jobs that the interns and the other doctors will need to do. And they might be going down to consult on a patient in the emergency department as they come in, or if they're doing admissions that day, if your team's on take, is what we call it in Ballarat anyway. So there's lots of different things and new patients to see all the time. You can also practice things like discharge summaries and outside of writing ward notes, sometimes it's just good to practice how you would normally do that, like how you would take notes. Sometimes if it's not necessarily a ward, like a ward round, you'll still need to go and see patients and do follow-up, or check med charts and things like that. So you'll often be going with a reg or the intern, and you might write progress notes for those patients as you're going around. So there's usually lots of stuff to still be done, but I would say that that's probably, don't get sucked into the vortex that is interns and regs utilizing you as a part of the team, which can be great and is awesome if they're you're a part of the team and you get to do things that are great for your learning. But there's going to be plenty of time later outside of MD2 to do things like write progress notes and discharge summaries. That's not what the aim is. So I would prioritize the patient side of things, and I would probably deprioritize. And I think there's another question somewhere else about like when you choose to go and do lectures and private study. That's probably when I would choose to go and do private study, is as soon as they're asking me to do things that they get paid to do and I don't. But yeah, I mean, learn once, do it once, and then you'll get to do it for the whole year of MD4. So, you've got time. And then for the rest of your life as well. So, here we are. But hopefully that answers that question, at least a little bit. If anyone else has anything else to add, feel free.
No, I think that was great. You covered it really well, Gemma. Someone's written how to balance lectures with also independent study and wartime, which I think is, Gemma touched on a little bit, but Anisha, did you have stuff to add for that too?
Yeah, it also relates to the question that's asked just underneath. So just generally balancing your own study with going and doing. So like ward rounds, clinics, whatever you can actually be involved in with the hospital. It's going to be totally normal to feel super overwhelmed by all of this for like the first month, 2 months, until you can like figure out a groove and find something that works for you. I remember at the very start, I was just like always behind. I would go to the things that I said I'd go to at the hospital, but then like actually trying to get your study done and kind of have some knowledge going into whatever you were about to throw yourself into was challenging. And I was behind a lot at the start. I guess what I'll say is rely on your peers. Like, you guys should help each other out. If you have study group, that is super helpful. You guys can teach each other things. I think, Tanny, you gave us some other resources aside from like the modules and lectures and stuff like that. I know some people who used exclusively those, did not touch the modules at all, and they're fine. They got through the year. Basically, you can get that information, the stuff that we need to know, you can get it elsewhere. You don't have to get it just from the lectures, but it is helpful to go and look at like the learning objectives, the things that we're actually meant to know. So what is it, Sophia or something like that, that tells you all the stuff that we're supposed to know for the year. It'll give you a full list of that. But also, if you don't feel like spending the time to go through the entire video, it will tell you at the start of the video the conditions that you were supposed to learn from that, all of the learning objectives that you were specifically meant to get out of that video for that week. So you can kind of compile a few of those and then go answer those questions on your own through like those Oxford cases or 100 cases in medicine. They're all fabulous resources, and some lectures, are really dry and hard to get through, so you don't have to commit all of your time to it. And I think even for us last year, the surgical sections were really painful to get through. They were just little focus cases, no videos, just learn about it by trying to like go through this focus case of a not real person. That was really tough, and most people, I think, didn't do that at all. They would have gotten that information elsewhere. AMBOSS, all of those clinical books, being taught by a peer. Yeah, so definitely you'll get into a groove. I know it seems overwhelming now, but you will figure things out. You'll find what works best for you, making the time to figure out what you actually need to know, even though like, I remember going on like neurology ward rounds with a few of you guys and being like, okay, great, we're learning about all of this stuff that is not in our curriculum. It was interesting, but I don't need to know about it for this year. So it's a bit of a trade-off.
Yeah, I think just quickly adding on to what you said about like those learning objectives and the videos, like I think that's a really good guide to know what you need to know. Like obviously the medical school is a bit tricky and like 95% of the content is about them, but the other 5% might be just random stuff. But what you find is like the videos will have like 5 like diseases or objectives you need to learn, but the video actually doesn't cover them. So you need to expand your learning just from lectures. I don't think you can go the entire year just doing the lectures, unfortunately. You have to look at other resources.
Definitely. And just Anisha, like triggered my memory with those surgical focus cases. I did maybe 1 or 2, and I just thought straight away, like, this is not for me. Like, I can't just sit down and learn this stuff without thinking about like the patient. And so I consolidated other resources for that. But just something specific to like the surgical blocks, I just want to say, don't get too bogged down in trying to learn like specific surgeries or techniques, because I think that's quite above like MD2 level, and it's just more about knowing sort of the principles of surgery. So like reasons for like why someone might need surgery, people who wouldn't be suitable for surgery, like so people that have cardiovascular conditions and couldn't go under anesthetic, just general things like that, and post-operative management of people coming out of surgery. So those sort of big themes are very important at the MD2 level, but definitely don't get too stressed about knowing specific surgical techniques or exact surgeries and new advances in surgery that you might think you need to know for certain conditions that are spoken about in those focus cases.
Yes, I'll also say,
hopefully
they've improved the surgical cases for you guys this year based on our feedback last year.
I would say as well, like, just if anyone's a little bit stressed about the surgical cases, I haven't done the modules where we had a different learning style, so I can't really talk to that. But I'm not a surge gal, like I said earlier. I think I've made that quite clear at this point. And I am not very interested in learning about it. So I didn't learn anything about surgical procedures. I think I picked, let's say that there are 4 quadrants in an abdomen. I picked the 4 most important things for each quadrant, like one of each, and I learned everything about those. I think I did like, gallstones, pancreatitis, diverticulitis, and appendicitis, and called it a day. And then I just went one bang in the middle, like, and that's literally it. They're the ones I really focused on. If they were anything minor, I just learned very brief information about it just to know what it was, and like I basically learned it as a differential and like a presentation, like Tani was talking about earlier. I didn't learn it in any other way or in any other kind of deeper thing. Yeah, I don't know. It worked for me. I got through, but I don't know how things have changed. But like, don't get bogged down, like Will was saying. I think there's more important things to learn, like why you're actually even speaking to that patient is way more important, and why you're considering them for surgery.
Definitely. Tani, did you want to sort of talk about that question about scheduling learning and stuff?
Yeah, sure. I'll be brief. I was very, very time poor in MD2. So Anisha, I was one of the people who definitely did not touch the lectures. But I think that what I did use them for is exactly as you said, like use the learning objectives. I would usually download the slides, skim them, get a vibe for what they are talking about, and make sure that I've touched all the topics, but I would not sit through the 1.5 hour lecture, because even on times two, some of them were painful. So I did use a bunch of other resources, and then I would usually, sorry, I sound like a plug for Anki, but I would usually learn something, pop it into Anki, and then as I kept on getting exposure to that topic, I would add it onto my Anki card, so it's consolidated onto a master note about A, that presentation, or B, that condition. So my learning is ongoing, but not necessarily lecture based, because I was like, look, if someone asks me about this condition, I'm not going to remember a 1.5 hour lecture. I'm going to need like the 5 most important points, the crucial investigations, and what do I care about managing them. And so that's what I would prioritize. And I think at MD2 level, that's what you're trying to get. And then MD3, you're trying to like fill in the scaffolding of like, okay, now I need to start caring a bit more about the management side of things, the allied health teams, and like, building that picture. But in MD2, you're like, what does it look like? How do I find out that this is what it is? And like, what is the basic management that is most important here, so the patient can be less crucial? But yeah, I think that's the way to go about it. And I think that's why the case books help, because it gets you into the thinking of like, how can I work them up? So I'm a big, big advocate for them. Lectures are great, but I agree, they also won't consolidate everything you need to know in MD2, because they say it's an investigation, like work up here, and then they chuck you with a bunch of management and you're like, hello, this was never in the lectures. So I think you, if anything, have to do a bit of outside study, and it's whatever works for you. It might be Ambos, it might be some textbooks that you really like. I'm a big like on-call first aid girl. Like the basics are important, and I think consolidating it accordingly is how I would go about it. So I was like, what is the bare minimum I can do to get everything across the board, and then work from there and build my knowledge. But I was definitely not a lecture girl. I never admittedly have been. So it is possible to not watch lectures. Some people love them though, so I won't shit on them.
I'll echo everything you just said, but minus the Anki. So like, you can also do it without the Anki for those who don't like it. But I did use PassMed in place of Anki. So like, I did still use some kind of like question-based learning. I just didn't find Anki works for me. But yeah.
Yeah.
And just about aligning. Oh, sorry, Adam.
Sorry to interrupt. I just also want to echo the non-Anki user here, because I feel like everyone uses it, but it's okay if you don't use it. I didn't use it and I did okay, so can't complain.
I'll echo. I did use Anki and it was good. Just with this, just on the same question, just about aligning like what you're learning in that week with what you see in the wards and stuff. Something that I did was I'd write down like in a big note, like sort of all the conditions I'd see. Like the first week I'd see AF and heart failure, and then the next week another patient would come in with AF, and then 2 weeks later I'd say, oh, AF again. oh, AF is so common in the hospital. And then that sort of made me see like where the important concepts were. And then I'd base my study off that, and then consolidate other resources, or put something into Anki so I'd keep getting that exposure, or do past med questions on it. But yeah, so I wouldn't worry too much about aligning like the modules with what you're learning. You can definitely use that. But I think just basing it off what you see in the hospital is quite a safe way to go, because those things that you do keep seeing in the hospital, those common things, are what they're going to most likely test you on in MD2. Just before we wrap up, I wanted to get to that other question, which was, what would you do if your supervisor isn't really good at supervising you? And I think that sort of can tend to be a bit of a difficult problem to encounter. The first thing that I'd probably suggest is trying to get more involved in your learning. And so some way you can do that is maybe, instead of telling the supervisor, oh, well, like, you're not supervising me, is maybe going to them with questions and saying, oh, do you think it would be okay for me to do this history? Or if you've already done a history, oh, what did you think? What feedback did you have on that? Rather than just waiting for them to give you feedback. So it's almost like you have to sort of get them involved in the supervision. And another thing that I'd say for that is, if you do try that, because it's always good to try and deal with it yourself first. But if that doesn't sort of change anything, you can always feel comfortable to go to your clinical school. And usually they're pretty good with being able to sort of deal with that issue, or maybe sort of move you to a different supervisor if you feel like it's not a good fit. But yeah, they're a really good soundboard to be able to sort of talk to those issues about. And I know that my group last year had a few issues with that sort of stuff, and they were definitely very helpful in navigating those sort of issues. Did anyone else have some experience in that sort of area with bad supervisors, or I'll move on? Yeah, that's okay. I mean, if no one's speaking, it shows that most of the supervisors that the uni chooses for you are pretty good, because they're usually volunteering. And so I think they're keen to teach, and the uni's definitely keen to make sure that you actually are getting the education that you need to be a safe practicing doctor.
I think it is actually paid teaching hours. It's not, I don't think it's
Yeah,
volunteer.
is it? Oh,
Yeah,
okay.
I think so. So
Certainly not volunteer.
Yeah.
It's well paid.
Yeah, so
Right,
they
well,
are
that's
paid
good
to
to
be there,
know.
which is arguably better incentive to do well.
Yes. Exactly.
95% of the time you won't run into that issue, but if you do, yeah, do what Will was saying. It's a good
Awesome. Great. So I think, just in the interest of time, we'll leave it there. So I just wanted to say thank you so much for coming tonight. Me and all the panelists hope that you've gained at least some little bit of insight into what you can do in these next few months to feel more comfortable in the hospital. And just, if you had any time, we'd love to hear some feedback about this event, what you liked about it, what you didn't like, so that as GSA we can provide better events for you in the future, and make sure that your graduate experience is a very good one. If you had any further questions about this sort of event, or GSA, or even about medical things, feel free to email me with the email there, which is coursework@gsa.unimal.edu.au, and I can forward questions onto the speakers or answer them myself, just to make sure that you can have a reliable answer with those ones too. Thank you so much to the speakers tonight. You all did a great job, and I hope that everyone has a great rest of the night, and that your MD2 placement goes awesome. Great. Thank you so much, everyone.